right, well, thanks everybody for joining. Those who are joining us for the first time, this is the second of two lecture series on management of cardiogenic shock by Dr. Parag Patel. Let me introduce him again. Dr. Patel is an assistant professor at Mayo Clinic, Florida, in the Department of Transplantation, and he is the medical director and fellowship director of advanced heart failure, mechanical circulatory support, and heart transplantation. He's been with Mayo Clinic since 2012. He has served on the cardiovascular committee for United Network for Organ Sharing and helped derive the current health allocation system. He spearheaded the development of the JACS Cardiogenic Shock Consortium, and he is now developing a hospital-wide cardiogenic shock tier alert program at Mayo Clinic. And actually, he shared that with us, and we're working with him and his team to implement that at Baptist Hospital. He has interest in managing patients with end-stage heart failure, left ventricular assist device, and heart transplants. I'll turn it over to you, Dr. Patel, and we're looking forward to hearing more about management of cardiogenic shock.
Thank you very much for the kind introduction. So we will be moving on to a little bit more advanced hemodynamics compared to last month's talk. So this is Cardiogenic Shock 201. And what we'll do is we'll provide a very brief review of kind of the basic concepts that we've discussed last month. And then we're going to add on a couple of concepts and then go straight to case studies to kind of solidify the understanding here. And the idea here is that when people are in end-stage cardiac disease and they really do have pump failure, it's important to utilize hemodynamics to best optimize these patients. I have no pertinent disclosures, but just like last time, Zoom's a very unusual format to give lectures, and so I'd like you to stop me at any point to ask questions, etc., just because it's hard to read the audience, of course. So let's start off with a review of basic hemodynamics. You know, I think we went over some very important rules towards managing patients, and one of the first rules that I showed you last month was that it's important to identify shock early before the progression of metabolic shock and implement therapies rapidly. I had showed you that shock comes in stages: the compensatory stage, where you're in a fight or flight response stage, where your homeostatic mechanisms are actually working quite well to keep you steady. And then you move to the progressive stage, where the homeostatic mechanisms can no longer compensate fully. And you first start off with a single organ insult, in this case cardiogenic shock, and then you quickly move towards a multi-organ insult where you have cardiometabolic disarray. And then the final stages are irreversible. And so as you recall in the first lecture, we kind of identified that it's crucial to identify the insult very early in this progression over here, because once you start adding other organs or metabolic disarray, it's harder to dig yourself out of the hole. The second rule we talked about is that it's important to utilize either an invasive assessment or a partially invasive assessment of hemodynamics to correctly classify the type of shock, because not all shocks are managed the same. And so we went into Hemodynamics 101, or the basics of hemodynamics, and I had showed you that whenever somebody is crashing, it's really important that you look at the three basic subsets of hemodynamic parameters: preload, contractility, and afterload. And anytime you have shock, you're going to have a derangement in any of these three hemodynamic parameters, and where the derangement is what's going to drive how you're going to manage the patient. And so when somebody is crashing, what you want to do quickly is identify what their preload is, look at their filling volumes, and if you have a PICC line, check the CVP. You know, you can use an ultrasound, look at the IVC, or if you have an invasive monitor, then you can actually check, you know, wedge or RA pressures. Look at your contractility. So if you have a SWAN, you can do cardiac output or index, or if you have a central line, you could check SVO2. And then finally, calculate or estimate your systemic vascular resistance, because there are types of shock where your resistance can be low, and we'll get into that in a second. And so again, when somebody is crashing, really think about these three parameters to best treat a patient. And as you recall, I gave you what the normal parameters are. So we went through rules of sixes. to look at filling pressure. So 6, 12, and 24, they're doubled. Oop. And so basically, if you know the 6, 12, and 24, you should be able to derive all the other normal hemodynamic parameters of the heart. Okay, I gave you what normal cardiac indices are. So we like using cardiac index because it can, it's indexed to body surface area. And so you really want to keep a cardiac index greater than 2.2. And that will give you an idea as to the normal values for contractility. And finally, the third value we want to look at is your resistance or your afterload. And you want to aim for a systemic vascular resistance of 800 to 1200. And so what you're going to do whenever somebody is in a decompensated state is you really want to invasively or even non-invasively guess what's going on with these three parameters. We also talked about ways you can kind of quickly get a quick assessment, and one of them was the poor man's swan, which is either a central line or a PICC line. So if you have somebody in a unit and they are moving in the wrong direction, you can utilize a central line to check a CVP or a central venous pressure. And remember, many of the PICC lines have valves in them, so you sometimes need an adapter to correctly estimate the numbers. I'll give you an example. Last week when I was on service, I asked our nurse to check a CVP from the PICC, and she told me it was 30, which didn't correlate with what I was seeing on exam. So I went up to the room and I noticed that the adapter was not attached, and she was one of our newer nurses, and so we kind of educated her on that, and we put the adapter in, and the CVP was 6. So you can use these devices to check a CVP, and then you can also check an SVO2 and utilize that as a surrogate for output. Remember, things that affect SVO2 include oxygen arrival or oxygenation, oxygen carrying capacity such as hemoglobin, cardiac output, and finally oxygen uptake or tissue demand. And as long as your carrying capacity or hemoglobin, your oxygenation, which are your lungs, and your uptake are steady, you can utilize SVO2 as a surrogate for cardiac output. This, along with a mean arterial pressure and a hemoglobin, will allow you to calculate a FIC. And if you calculate a FIC and you have a CVP, you should be able to estimate systemic vascular resistance. And so I think the central line or a PICC line is a very good, cheap, and quick way to assess hemodynamics. The third rule I showed you was that it's important to identify the type of shock because, again, not all shocks are treated the same. And so when you have cardiac output, filling pressures, and systemic vascular resistance, you can utilize the derangements to kind of guesstimate what type of shock is going on, whether there's cardiogenic, hypovolemic, distributive, or obstructive. As you recall, cardiogenic shock has a primary insult in the cardiac output. Hypovolemic shock primarily has a decreased filling pressure. Distributive shock occurs when your systemic vascular resistance actually goes down. An obstructive shock, as you recall, there are two types. There's either external, which would be tamponade, or internal, which would be PE, would have derangements based on the type of or the cause of the obstructive shock. So you're going to utilize those hemodynamics to differentiate your shock. So then after we kind of talked about that, we moved on to hemodynamics 201, or advanced cardiogenic shock. What we showed was that the job of the right heart catheter, the swan, is to help you identify, is there a hemodynamic derangement? But then you want to actually think about it a little bit more, and you want to use kind of advanced measures of hemodynamics to answer two questions. The first is the derangement contributing to poor organ perfusion? And the second is, if perfusion is not adequate, is it right-sided, left-sided, or something else? And so let's get into that for a second. So how do we tell whether a derangement is contributing to poor organ perfusion? One of the numbers we look at is cardiac power output. Okay, so cardiac power output is an integrated measure of cardiac function that accounts for both the flow generating and the pressure generating capacities of the heart. Okay, and if you have temporary mechanical circulatory support, it actually measures the flow generating capacities of temporary mechanical circulatory support in addition to the pressure generating capacities of the body. And so it's measured by mean arterial pressure times cardiac output divided by 451, or Fahrenheit 451, as I've told you. And a normal cardiac power output is going to be greater than 0.6. So remember, mean arterial pressure times cardiac output divided by 451, and normal is greater than 0.6. If you have a cardiac power output greater than 0.6, you can make the assumption that in most cases you have enough perfusion to your organs, and that even if there's a derangement, you have adequate forward flow. Okay? Does that make sense? Any questions so far?
Are you getting cardiac output non-invasively by echo, or is that work in that formula?
We traditionally will use invasive measurements once you get to this point. So I think you could try to get cardiac output by echo, but again, there are some inherent limitations to that. I think you could potentially use, if you had a PICC line in place, you could utilize a PICC line as a surrogate for a FIC and utilize that as well. So we typically, again, we're a little biased as heart failure transplant docs, but we typically are biased towards utilizing invasive hemodynamics to assess patients in cardiogenic shock. And Brent, there's a lot of data that's come out more recently, not randomized, but data that's come out more recently that kind of support the utilization of invasive hemodynamic monitors in patients with cardiogenic shock. If you stratify outcomes of patients in cardiogenic shock based on utilization of a SWAN, patients who had a SWAN definitely had a significant improvement in their survival compared to those who didn't. So I don't think it's the SWAN, I think it's the data that's provided as well as the expertise of the people who are utilizing it. So
Thank you.
we typically do that. Great question. So again, the right heart cath lets you know if there's a hemodynamic derangement. The cardiac power output lets you know whether the derangement is contributing to poor organ perfusion. And so if your cardiac power output is low, if your SVO2 is low, or your cardiac index is low, these three actually will give you an idea that, oh my gosh, we need to think about why we don't have adequate organ perfusion. The reason why I like CPO over cardiac index and SVO2 is that CPO takes into account both the flow generating capacities of the heart as well as the pressure generating capacities of not only the heart but also the systemic vasculature. So it actually is a nice integrative function that allows you to get an idea as to whether you're having issues with perfusion. Now, if you are having issues with perfusion, the next question is to identify where the issue is from. And so question 3 is, if perfusion is not adequate, you want to see, is it right-sided? Is it left-sided? If it's LV failure, or the other thing is sometimes you could actually have an Impella in and still have a low cardiac power output. So you want to see, are you having inadequate left ventricular support with temporary mechanical circulatory support? So let's get to that. So how do you determine whether it's left or right-sided? What we really want to do is we want to keep in mind that the right owns the left. So this guy, even though he's out of shape, this guy definitely controls the LV. The little brother that's out of shape will definitely control the bigger brother. And so remember that if you have an RV that's not functioning well, then the RV will be unable to fill the left ventricle, and you can do all you want to support the LV, but it's not going to work. And also keep in mind, whenever you give left-sided support, so let's say you have a failing left ventricle and you put an Impella in on the left, you will get a little bit of RV dysfunction for 2 reasons. Number 1, when you decompress the left ventricle, your septum will move leftward. And number 2, you increase the preload, you increase the volume that comes back with temporary support. And so your lateral wall may be displaced as well. And so when you change the morphology of the right ventricle can fail. And so the calculation that we utilize to determine whether the right side is the problem is Poppy. And remember, like I said before, I like it when you call me Big Poppy. Big Poppy is always better. Poppy stands for PA pulse pressure, so that's PA systolic minus PA diastolic divided by your central venous pressure. So what this means is it looks at the pressure generating capacity of the right ventricle, and you're getting rid of any backflow because backflow is bad. And so in general, an abnormal POPI in a patient with heart failure is less than 1. And remember, because temporary mechanical circulatory support typically leads to a little bit of RV dysfunction, you need a little bit more room. So if you have an LVAD or if you have an Impella, your goal POPI is going to be, or the abnormal POPI is going to be less than 1.5. So you want a POPI greater than 1.5. Okay? And so if you have somebody crashing, what you're going to do is you're going to use the right heart cath to determine if it's cardiac in etiology. You're going to use a cardiac power output to determine, are you contributing to poor, or is the derangement contributing to poor organ perfusion? And then you're going to use the POPI to say, okay, if your cardiac power output is low, is it due to the inability of the right to fill the left? And if your POPI is low, then you can blame it on the right, more likely. And if your POPI is normal, then you want to look on the left side for either LV failure or, if there's support in place, inadequate LV support. I'll stop there because this is kind of there are 2 important slides. This is one of the most important slides. Does this make sense?
It does.
Okay, good.
Yes.
Can I ask you one question about POPI?
Yes.
This is off subject, so you don't have to. Is POPI used also when you all are assessing a normal, not a normal heart, a heart we're sending you for possible LVAD, or is that different?
100% actually. So if we have a low, like what we've learned very quickly is echo-derived parameters, including TAPC, have an okay predictor, of post-VAD RV failure, but POPI is actually a very strong predictor when you optimize them. And so what we will do, if somebody came to us needing an LVAD, we will do a right heart cath, look at their POPI, and then optimize them and see what the POPI is at that point. And if your POPI is greater than like 1.5, we feel pretty comfortable going for an LVAD. If your POPI is close to 1 or less, then left ventricular support's not going to help the patient. The patient will probably have RV dysfunction and need inotropy. And so in those patients, we typically will try to go straight to transplant. If you're between 1 and 1.5, so that grayish area, you know, sometimes what we've done is we may actually put in an Impella 5.5 and test the right ventricle. So after you optimize somebody, you may put an Impella 5.5 and see what happens to the right ventricle over 3 to 5 days, and that will give you an idea as to whether they're going to be able to tolerate an LVAD. So we definitely use it. So great question.
So let me just ask you one follow-up on that, and I don't mean to get you off subject. If we're sending you we're in the process of working up a patient that we think may need an LVAD, and we happen to do a full right heart cath, and the patient's on milrinone or dobutamine, should we measure the POPI? Should we take them off that medication, and how long to give you an adequate POPI measurement? Or would you say just keep them on that med and report it to us?
Yeah, I think what I would do is just keep it on the med and report the POPI to us. I mean, you know you're in trouble if you have a POPI of 1 to 1.5 on the inotropes.
Right.
So, and then when we get them over here, if they're a candidate, we may actually hold the inotropes after optimization to see how they do. So with milrinone, they may be an inpatient. We hold it for about 3 to 4 hours to 6 hours. With dobutamine, we feel pretty comfortable holding it for 30 minutes and getting an idea. But usually, even you know, you bring up a great point. What does a POPI mean to us on inotropes versus off? You know, I don't have any like papers that actually specifically kind of address that. But in general, if I have a borderline POPI on inotropes, I know we're going to have trouble without it. If that makes sense. So great questions. And now this is the second most important slide. And I'm going to kind of highlight it here, is that let's say you have somebody, and this is a new slide. So this is adding to the dynamic parameters that I talked to you about. Let's say you have a patient with refractory shock or cardiogenic shock. How do you know what type of device you need to place? And so this is really going to integrate the right heart cath hemodynamics as well as the hemodynamics 201, the cardiac power outputting POPI. So let's say you have refractory shock, okay? What you would want to do is you want to look at your cardiac power output, your POPI, your right atrial pressure, and your wedge to help you decide what type of shock is going on. So if you have cardiogenic shock, typically your cardiac power output is low. It's less than 0.6. So that's question 2. Question 1 is there's a derangement. So that's here. Is there refractory shock? Question 2 is are you perfusing your organs adequately? And their cardiac power output in all 3 of these cases are low. Then the next question you're going to try to decide is it right or is it left? Okay. And so let's look here and look at patients whose POPI is actually greater than 1. So if you have a POPI greater than 1 and a cardiac power output less than 0.6, you know that you have deranged hemodynamics and it's primarily left-sided, okay? And you can kind of continue to see that with a lower RA and a pretty high wedge. So if you have somebody with LV dominant cardiogenic shock and they have hypoxia, then you need to kind of think about left-sided support that has oxygenation capacities. So that would be a tandem heart with an oxygenator or a centromag with an oxygenator or VA ECMO with an LV with an oxygenator and LV vent. If there's no hypoxia, then you can think about an Impella CP or an Impella 5.0 because you know that your right ventricle with a POPI greater than 1 is probably going to be able to tolerate the Impella. Okay. If you have a low cardiac power output, meaning you don't have enough perfusion, and your POPI is low, okay, then your question is going to be, is it right-sided alone, or is it right and left that's causing your issues? So the way you differentiate these two, because both of them will have a high CVP, okay, is you look at the wedge. So if your right is so weak that you can't push enough flow to the left, typically your wedge is going to be low normal or mildly elevated, so wedge less than 15. Okay, so if you have a wedge less than 15 and an RA greater than 15, again, your RA is higher than your wedge, then you can make the assumption that you're dealing with RV dominant cardiogenic shock. If there's hypoxia, then you still need to go the ECMO route or anything with an oxygenator route. And if there's no hypoxia, you can think about an RP Impella, a right-sided Impella, or a ProTech Duo, which is a tandem device that you can also place in on the right side. If you actually have the same parameters as RV dominant cardiogenic shock, but you have a high wedge, so typically in these patients you have a high RA and a high wedge, this is biventricular failure. You could put a right-sided device in this patient, and what will happen quickly is that as you improve flow from right to left, the left will fail. And so then you end up having pulmonary edema. So if you see this where you have a high wedge, high right atrial pressure, a low POPI, and a low cardiac power output, you really have to be careful with considering right-sided support or even left-sided support. These are the patients who are the sickest and would need biventricular support if there is a out or a strategy, as we've talked, exit strategy, as we talked about. So in these patients, if there's hypoxia, use an oxygenator with a tandem heart or a centromag, or you can use the ECMO. And if there's no hypoxia, you can think about a bipella, so a right and left Impella, or you can do a tandem heart ProTech Duo combo, or what we like doing here is we may put a 5.0 Impella on the right axillary side and a ProTech Duo on the right IJ. And so that's your biventricular support device. And you can ambulate these patients while they wait for either recovery or transplant. So on the right over here is pretty much somebody who's doing fine, and you don't even have to look further because this guy's cardiac power output looks normal and the POPI is normal. So again, utilize your POPI to decide, is it isolated left or is it right or biventricular? And then you utilize your filling pressures to give you an idea as to whether it's biventricular or right dominant. Does that make sense? This is the most important slide in the talk.
Yes.
Okay, good. So now we're going to put you guys to the test. So some of these case studies are added from last talk, just to kind of refresh your memory, and then we're going to get into some pretty complicated cases that are real cases. So let's start off with this one. So the first case is a 35-year-old non-ischemic cardiomyopathy. EF is 20%. Comes in with heart failure, and you place them on inotropes. They failed inotropes, so you put an Impella CP in the right femoral artery. The patient started doing very well after the Impella was placed, but 3 hours later, the patient became acutely hypotensive, starting having non-sustained VT and flows of 1.5 liters per minute. So what is the cause of the patient's decline? Is it RV failure, bleeding, sepsis, tamponade? Maybe you need more support with the Impella 5.0, or is it VT?
Arterial pressure of 68, cardiac output 3.4.
And again, this patient's declining here with a map of 50 and low flows. So
give us the choices again now.
So it's RV failure, bleeding, sepsis or a drop in preload, tamponade, Impella CP support's not adequate, or VT. So
can you just remind us when we have RV failure and we have mechanical support, how long before we decompensate? What's the time frame?
So it's a great question. It can be at any point. So some people, after an Impella is placed, will develop RV failure immediately. And some people will actually develop it when there's about 3 to 6 hours later. Occasionally I'll see people stay steady on Impella until they get a second insult like sepsis or VT or something of the sort. So I'm glad nobody's answered this question, because you guys are doing a great job, because you need more info. Okay, so this was a trick question, because this case highlights the fact that you need hemodynamic parameters to help you troubleshoot a patient. So we have this stem, and then if you take the patient, you say the CVP is 2, the PA is 16/6, and the SVO2 is 46%, and on the VBG your hemoglobin is 7, okay, you can know that this patient's probably hypotensive because of bleeding. Right? You have low filling pressures, a drop in SVO2, which you can see in acute anemia, and a low hemoglobin. Okay? So that makes sense. But now let's say we change the hemodynamics. So we take the same patient, okay, but I give you completely different numbers. Okay? We take the same patient who's hypotensive, and I say the CVP is 18, the PA is 24/14, the wedge is 14, and the SVO2 is 46%. Now that you have, sorry, go ahead.
I said low PAPI.
Say that one more time, I'm sorry.
Calculate the PAPI, it's 10/18, less than 1.
Perfect. And so what you did there is, in your head, you did the cardiac power output, which is basically mean arterial pressure of 50 times the cardiac output of 1.5 divided by 451, Fahrenheit 451, and you got a low cardiac power output. Remember, cardiac power output should be greater than 0.6. And so you said, okay, we are not perfusing well. So is it right or is it left? And so then what you did is you basically took your PA pulse pressure, which is 10, PA systolic minus diastolic, divided by 18. It's definitely less than 1, it's 0.56. And so, as you had mentioned, this is RV failure. So you use those advanced hemodynamics to say, this is a patient who developed RV failure after an Impella, and so the right treatment for this patient would be giving them inhaled nitric oxide and place an RP Impella. So great job. Now, let's change the hemodynamics again. Same exact story. And this is why I want to highlight the importance of hemodynamics, highlight the importance of a PA catheter in patients who have temporary mechanical circulatory support, because it allows you to make faster decisions, more accurate decisions when troubleshooting them. So if you have the same patient, you have a CVP of 11, a PA of 45/20, a wedge of 20, and an SVO2 of 46%, and the patient's on an Impella and 2 inotropes, what's the next best step? What you're going to do, again, is you're going to calculate everything, okay? So you're going to calculate your cardiac power output, your POPI, and then go try to decide what's going on with the patient. So the cardiac power output's unchanged. Remember, it's 50 times 1.5 divided by Fahrenheit 451. So it's 0.17, but your POPI in this case is different. You have a POPI of 25, so that's 45 minus 20, divided by 11, so you're 2.27. So when you see those two numbers, what you're going to say is, yes, there is a derangement. Yes, it's affecting our perfusion, but it's not due to the right ventricle, okay? So then what's going on with this patient is you have inadequate support with your left-sided Impella. So what that means is either your Impella is not properly placed, so you do an echo and you look at that and make sure that's not the issue. And if that's not the issue, you may need more support, which typically means upgrading your Impella to a 5.5 or even think about ECMO or the next step if needed. Okay. Any questions so far?
Awesome.
Quick question. How low is the threshold before you put the swan guns in a patient with cardiogenic shock? Is it 1 inotrope, 2 inotropes, before you put them on inotropes?
So that's a great question. I usually, what I'll do is, let's say somebody's in low output heart failure and they have, you know, metabolic disarray, then I'll be quick to put a swan. But let's say they're kind of borderline, then I'll usually try 1 inotrope with a central venous catheter, whether it's a PICC line or a central line, and I'll trend the SVO2s. And if the SVO2s are moving in the right direction, you probably don't need to you don't need to put a PA catheter in. If somebody gets a Impella, 100% of them at our institution are getting swans. And I think that is that should slowly move over towards best practices at all institutions, because we have identified, and I'll show you a case here shortly, we have identified cases where patients may have not been optimally managed without invasive hemodynamics. So I don't think you need to jump to a PA catheter in all these patients. You can get away with a PICC line. We do it all the time. But then once you move to dual inotropes, or if you're failing single inotropes, I think what you want to do at that point is quickly identify how sick you are, where the issue is, whether it's biventricular, right-sided, or left-sided, and really make a quick decision based on whether you go the Impella route or a second inotrope route. And as you recall from the last lecture, the more inotropes and pressors you add, the greater the mortality. And so you really don't want to wait until you're deep into cardiometabolic disarray before thinking of temporary mechanical circulatory support. As I said in the last talk, if you look at kind of historically when we've utilized temporary mechanical support over the last 5 years, if you look at our history, I think in the past we were very late to the ball game in terms of placing these. And slowly over time, as we felt comfortable with this and we've identified patients earlier, we've been placing Impellas earlier within the kind of spectrum of cardiac decline. And so, and if you place it in earlier, those patients tend to have better outcomes, you know, anecdotally. And I'm sure even within the studies as well.
So along those lines, Parag, is there any place, going back to the case with the RV failure, is there really any place for, well, you had one where dobutamine was a choice.
Yep.
Obviously, you're supporting mechanical assist, but is there any place for dobutamine with RV failure as a temporizing while you're getting ready to put in an RV?
Yes. I agree with you 100%. So I, for purposes of this talk, this patient was already on dobutamine milrinone.
Yeah.
I kind of erased it, but you're right. So let's say they're not on dobutamine milrinone. There's definitely a place for that. I think once you get above 7.5 to 10, you're not going to get much bang for your buck. We like mixing dobutamine with nitric oxide, or if you guys have inhaled Flolan, you can do that.
Yeah.
But you even if they don't have high pulmonary pressures, because they won't, right? So when you have RV failure, your RV is not able to generate high pulmonary pressures. And as a result, some people will question whether nitric oxide or inhaled Flolan is of use, but we purely use it as an RV afterload reducing agent. And we've had very nice luck with it. In fact, we've been able to avoid RP Impellas and Protect Duos with just nitric and dobutamine alone. So I think it is very reasonable to start working on that, but start working on your plan B if it doesn't work at the same time, so there's no delay. So that's a great question. I definitely think that is very reasonable. Let's get us to where we're, oh, you may have seen my next question. Any other questions at all? All right, so the pearl there is that invasive assessment of hemodynamics imperative to correctly classify and manage shock. Again, the same stem, but different hemodynamics led to different treatments in the same patient. And so that's why, you know, I highlight that. And so we're gonna take a little bit more complicated patient now. We're gonna go through this slowly, and this is a true patient. This is, in fact, I just saw this patient in clinic last week, but this is a 70-year-old whose wife was a nurse at Mayo, diabetic, actually, aside from diabetes, very healthy, was golfing the day before this all happened. And he came with a non-STEMI and an EF of 29%. Okay, it's unclear whether the EF was new or not. They took him to the cath lab to look at his coronaries, and while getting him prepared on the table, he became acutely dyspneic. His SATs dropped to 88%, and he had been 120s, and his pressures dropped to 95. So they intubated him, and the interventionalist immediately placed an Impella in prior to angiography. In fact, what he did is he stuck an LVDP in, the LVDP was 36, placed the Impella, and then went straight to angiography. During this time, the anesthesiologist had put him on an epi drip, and the cath was remarkable for 100% RCA lesion. There were left to right collaterals. There was a prox LAD lesion of 99%, a prox circumflex lesion of 99%. And interestingly enough, of course, surgery said no to urgent surgical intervention. And so our interventionalist actually stented the LAD nicely and actually jailed, stented the circumflex, but jailed the left to right collateral. So it was interesting. There was marked decreased flow in the right collaterals after placement of the circumflex stent. This patient did not have a swan placed after the Impella was placed, and he went to the ICU with a MAP of 75, a cardiac output on the Impella of 4.1, on epi of 0.08 micrograms per kilogram per minute on P8. So through the night, so he got out of the cath lab at around 6 o'clock, but through the night, the patient became increasingly hypotensive, and the team had increased pressors, including epi, levo, and vaso. And we weren't involved in this case until the next day, but every hour epi was pushed up, vaso was pushed up, levo was pushed up, but there wasn't actually a aggressive assessment as to what was going on. Why is this going on? So, you know, obviously we're called and they're saying, why is this patient hypotensive and what's the best step for treatment? And our answer is we can't tell just based on this, because the patient could be bleeding because maybe we need to transfuse. Maybe the patient's septic. Maybe there's RV failure and we need an RP Impella. Maybe the patient has inadequate support, or maybe the patient's hypotensive because of vasoplegia. And so the next,
you know, they jailed the collaterals to the right.
Yeah.
You would have thought RV dysfunction, but
and you know what? When they called us and I looked at the cath, I'm like, we are going to need to get an RP Impella in quickly. And I actually talked to our interventionalist, and I actually put a swan at the bedside, and was slightly surprised. So these are the hemodynamics. We got a CVP of 11. Okay, we got a PA of 40/20. And we got a wedge of 16, a mean arterial pressure of 51. Now, interestingly enough, the cardiac output was 4.5 and the PA saturation was 69%. Labs came back with a hemoglobin that looked good. There was definite acidemia with a pH of 7.2, and oxygenation was okay at 75. When you look at the advanced hemodynamics, if you take mean arterial pressure times cardiac output divided by 451, you're on the low side. Your cardiac power output is low. But interestingly enough, your POPI is 20 divided by 11, so your POPI is 1.8. So the RV was not the cause in this patient.
Wow.
What was interesting is this patient had an SVR of 711 and a lactate of 5. So we have a low cardiac power output. We know it's not due to the right, so you're making the assumption it's the left based on what I've taught you. But what was kind of intriguing was that your output was 4.5 and your SVO2 was okay. So maybe it's not the left. And what I want to highlight to you is that cardiac power output is an integrated measure of the flow and pressure generating capacities of the body. And there are cases where you can get a low cardiac power output that's not due to left-sided issues, but due to drop in vascular tone or low SVR. And I'll show it to you in the next slide. But in this case, the patient was hypotensive because the patient was acidemic. Okay? And so this patient had vasoplegia. We corrected the acidemia, we increased the pressors, and over the course of 3 to 4 hours, things got better in this patient.
Cool case.
So
quick question, Parag.
Yes.
Have you checked the quick echo? I mean, there's always a chance of tamponade in these situations. It's complex procedure.
That's an excellent point, and we did do a bedside echo even before we did the right heart cath, and that was on the differential. For purpose of this talk, I didn't put it in there, but I think an echo is crucial in anybody with an Impella that's declining, because you can get those type of issues. You can also get migration of your Impella and inadequate forward flow from that. So great point. I think an echo is crucial, and I'll get into that here in a second. So the pearl here is that cardiac power output can be influenced by LV function, temporary mechanical support adequacy, right to left filling, and vascular tone. So anything that allows for forward flow out of the heart, as well as the tone from the vasculature, that's going to affect your cardiac power output. And this is a little cartoon to kind of highlight this. And so if you have anybody with a low cardiac power output, and you have a low POPI, you're thinking that the RV is your issue. And in your differential, you're going to think of RV failure. You're going to think of PE or tamponade, where the echo is going to be useful. Patients with pulmonary hypertension or VT can have right-sided failure. Or you can have volume depletion or bleeding, because in the setting of volume depletion or bleeding, your right's no longer able to push to the left. If your cardiac power output is low and your POPI is normal, then you need to think about the left ventricle, and you need to think about the systemic tone. So if it's the left ventricle, think about LV failure, think about Impella positioning. Maybe the Impella is not positioned appropriately, or maybe the Impella is not strong enough. Maybe the CP Impella is not enough, and you need something that provides more support. If your primary problem is mean arterial pressure, then, think about vasoplegia, like our patient, because of acidemia. Sometimes you can get hypoxia and drop in your SVR from that. Sepsis is notorious for tricking you on this as well. And then again, bleeding. So if you get this concept with what we've taught you before, you should be well equipped to help utilize hemodynamics to troubleshoot these complicated patients. Any questions so far?
Well, I mean, when you, this is not the teaching point, but he's acidotic. Were you worried about ischemic bowel, or you guys just corrected the acidosis with bicarb and the ventilator and he got better?
We lucked out, but that was also on our differential, because anytime you manipulate an Impella, obviously you worry about clot going to the wrong spot.
Right.
So we did, he was intubated, had a pretty benign abdominal exam. However, because of the lactate of 5 that was unexplained, we actually did get general surgery on board just to look at it. What was nice though is usually if it's GI related, you can push bicarb and it's not going to really rapidly correct. And in his case, it rapidly corrected over 2-3 hours. So we felt pretty comfortable it wasn't it. But you're right, if you're pushing bicarb and your lactate goes from 5 to 4.8 and you gave 3 amps of bicarb, you're in trouble. Right. And so, so great point there. Now, this is, again, same patient, but we gave the patient a little bit of levo, gave the bicarb drip with some pushes of bicarb. The acidemia got better. We weaned off the levofed, and he looked actually really good the next night. However, at 6 a.m., the patient had a temperature of 100.3, and 30 minutes later, he had monomorphic VT at 165. Now we're entering the world of the electrophysiologists. So they'll be able to help us out with this one. What was interesting was that when the patient, right prior to the patient having monomorphic VT, the hemodynamics were as followed. You had a CVP of 10, a PA of 39/18, a wedge of 18, a cardiac output of 4.1.
Wow.
Your SVO2 looked good and your MAP looked good. So everything didn't look too bad. Oh, sorry. So choose all that are not first options for treatment. I hate these type of questions because these are on the boards where they use all these mixed words, but what wouldn't you do in this case of a patient? Would you immediately cardiovert this patient? Would you give amio or lidocaine? Would you decrease the Impella to P6? Would you do an echo to check for positioning? Or would you perform CPR in this patient? So again, the patient's in VT, but you have a MAP of 65 and adequate hemodynamics.
Choose all that are not first options.
So what it's basically—
I think you would cardiovert him, wouldn't you? Or I would worry that the Impella is up against a wall or causing arrhythmia. I would do an echo.
Good.
Help me out here, Tabit.
Well, I mean, he said that it's hemodynamically stable, so I would not do CPR.
I wouldn't do CPR.
And I'm glad ablation is not an option. I think, you know, thinking of mechanical trigger for VT is always something to consider, whether doing a heart cath or putting an Impella or anything else. So it's always in the mind. I think amio and lidocaine drip is always also a good option. Cardioversion, as you know, it's always the first option when you have hemodynamic instability. But with this guy, if he's hemodynamically stable, I would not go there first. So I would go the first and the last, like highlighted, not to be the first to be done.
I agree. Great. Well explained. I don't need to even go any further, but this is a patient with stable VT. And remember, most patients tolerate VT with a ventricular assist device or an Impella as long as the right side's able to push to the left in VT. And so you're able to see that your SVO2 is okay, your MAP's okay. So you want to try conservative therapies first with an antiarrhythmic. You're right in the sense that sometimes you can get suction events and your Impella may be irritating the ventricle, as Tabet said. So you want to kind of decrease the irritation on the ventricle by reducing your Impella to P6 or P4 if you can tolerate it. And maybe stick an echo on and see is the positioning off. Maybe it's actually a little deep and it's irritating the ventricle. And I can tell you on a different patient, there's a patient with a 5.5 Impella that was having VT every day for 3 days, and they kept on giving antiarrhythmics. And I got on service and I stuck the echo on board, and the Impella was just too deep. I pulled back and the VT just went away.
Yeah.
So you definitely want to try conservative measures first. And so remember that VT should be managed by ACLS algorithms with some caveats. Number one, VT is well tolerated. So start off with conservative strategies similar to stable VT protocols. You don't necessarily have to jump to CPR or cardioversion. If you do have a device stop alarm, or if there's inadequate flow or SVO2 due to VT, then you definitely should do CPR and cardiovert. Remember that a pulse is not a reliable metric for resuscitation because a lot of these patients don't have much of a pulse because the Impella's doing all the work. And if you need to defibrillate externally, leave the Impella running. But once you shock the patient, get restoration and activity, make sure you check your position afterwards, okay? And so it's really interesting. So we take that patient, and prior to the VT, the hemodynamics were like this, okay? So a little different story. This is the true part of the story of the patient. You had a low MAP, you had an RA of 22, you had a PA of 38/25, a wedge of 24, an output of 2.9, and an SVO2 of 45%. So again, you have a low MAP, low output, high left-sided filling pressures, probably greater right-sided filling pressures than left-sided filling pressures, and that's evidenced by the advanced hemodynamics. Your cardiac power output's less than 0.6, like we talked about, and your POPI is less than 1. So you have RV dysfunction, okay, in this case. So what is the least likely cause of VT, okay? Is it ischemia, the PA catheter causing kind of an irritation of the heart? Inotropes, because patients can have inotropes and become irritable from a ventricular standpoint. Maybe the Impella migrated. Maybe you have RV failure and suction events, meaning the right ventricle is not able to push to the left gets smaller, and when the left gets smaller, the Impella causes a suction event and actually irritates the ventricle. Maybe there's electrolyte abnormalities, or is there volume depletion causing suction? Which is least likely cause?
I would go for electrolytes abnormality.
Okay. And this is a tricky question because we don't have any labs. So definitely electrolyte abnormality is quite close, but the answer here is volume depletion because you have a CVP of around 22, right? So this is definitely a patient that's not dry, but just as a teaching point, you can have patients with a CVP of 4 or 5 with an Impella that have VT, and the reason why is the ventricle is small because of being dry. So in this case, the least likely cause of VT is volume depletion. What I wanted to show you here is that there are potentially 6 causes of VT in these patients. So when somebody has an Impella and you actually are managing VT, it's not enough to manage the VT alone. You're going to want to also troubleshoot and figure out what's causing the VT. And so let's say you stuck an echo here and you show an underfilled LV with a large hypokinetic RV, which is what we expected with these numbers. Then what we want to do is we probably want to either increase the inotropes, as Brent said, or we want to provide inhaled nitric. We may want to decrease the Impella to P6 because when you decrease left to right flow, when you decrease flow from the Impella out the body to the right ventricle, that may help the right ventricle get a little bit stronger. We may want to adjust the Impella if it's deep to reduce VT. Again, this is a patient that had a fever, and fevers can cause the ventricle to become irritable. So we may want to give antibiotics and do cultures. And when patients are a little hypotensive, we can sometimes change propofol to Versed. But what we don't want to do is upgrade to an Impella 5.0. Our problem is not left-sided here, okay? Sorry, I should have asked you this question, but this is a patient, again, with right-sided issues that could contribute to VT. In terms of left-sided issues that could contribute to VT, it'd be all mechanical, like the Impella irritating the ventricle. So again, you want to identify the potential cause of VT and address it.
So let me just ask you this. In a hospital like ours, where we don't have Mayo Clinic fellows here overnight, do you think it's reasonable to have an algorithm where your ICU nurse, somebody goes into monomorphic VTAC, pull the device back slightly, or is it reasonable to do that while the doctor's racing into the hospital to see the patient, or wait until you...
I would, if they're stable monomorphic VTAC, I would wait and have them, the algorithm would be like pushing amnio, getting labs to make sure there's no electrolyte issues,
right,
getting the hemodynamics, but we do not have them manipulate the Impella
at all
unless needed. And let's say you had a CVP of 2,
yeah,
and while you're driving in, you can tell them to give volume.
right.
If your CVP is 20, then that's probably not going to be the issue. Now, what I will have them do, if we troubleshoot that and we don't find a clear cause, I mean, the hemoglobin's okay, the CVP is okay, I will have them decrease the Impella till I come in. So,
right.
So I will have them go from P8 to P4 and let me know what the hemodynamics look like 20, 30 minutes late, like 10, 20 minutes later as I'm coming in. So we definitely will do that, but I will not have them move the Impella. And if it's in the wrong spot, even just reducing it a little bit will help you out.
Got it.
Just one comment on the catheter-induced VT. It tends to be, like you said, mechanical by the tip or the point of contact with the ventricle. It tends to be non-sustained more than sustained. And also the morphology of the VT gives you the clue. If you are inducing the outflow tract of the right ventricle with the swan, you would get a morphology of right ventricle outflow tract where it is positive in the inferior leads. The point is, you can rely on different features that will make one option more likely than the other.
Right.
And I wish I knew 20% of what EP docs knew, because in this case, and I didn't include it in this case for purposes of this talk, but this patient continued to have recurrent VT. We tried 20 different things, got our EP guy on board, and Dr. Venkat said, oh, this is coming from the RV outflow tract. And we pulled this, we kind of manipulated the swan. It didn't help us. And long story short, we had to go downstairs and map him and actually do a VT ablation in him. And not for purposes of this talk, but he actually ended up having recurrent VT for almost 12 hours intermittently until we could get him down to the cath lab to undergo an ablation. So really interesting.
But did removing the swan break the VT at all?
No, I was hoping it would. I mean, he had more, like, he had runs of it for like a minute and then would stop here and there. But, you know, we were high-fiving each other because after we removed the swan, he was quiet for about an hour and a half. And then all hell broke loose again. And so when he mapped it, when Venkat mapped it, it was coming, and again, I'm not sophisticated enough to know exactly where it was, but it was near the RV outflow tract. He ablated it, and we didn't have any additional VT subsequently. So any other questions here? So what I wanted to kind of show you is a case where you could have within minutes different insults that lead to hemodynamic disarray, and you have to address each insult. So, you know, you had a patient who have several potential etiologies of the VT, whether it's the fever, ischemia, and RV dysfunction, maybe they're scar-related VT, and, you know, VT provokes more ischemia, but all of those can alter your hemodynamics. It'll drop your SVR from the fever standpoint. You may have a drop in right to left filling in both of these cases, which will, of course, reduce your popping, your cardiac power output. And so you want to actually treat these insults based on the hemodynamics as well. And so you want to give them antibiotics, pressors, propofol, maybe support the right ventricle a little bit, maybe support the VT and hope it works. And sometimes it works, sometimes it doesn't. But, you know, utilizing hemodynamics will give you your best bet at identifying what the insults are and actually addressing it. So the teaching point there is, again, a coding patient is different. If they have temporary mechanical circulatory support, you manage them a little differently than those with. And again, do not treat the VT alone. You need to identify the cause of the VT. And we have a couple more questions real quick. So let's say you take the same patient and you gave them inhaled nitric to support the RV. You increased the butamine like Brent had mentioned. You decreased the RPMs, and you supported them. You weaned off the butamine. What I didn't include in this stem was actually doing the ablation, which helped us a lot. You wean off the butamine, and then the nurse calls you like a couple days later here with a urine output of 20. Hemodynamics actually look okay. You have a map of 68, a poppy that looks good, a cardiac power output that looks good at 0.6, but your hemoglobin is slowly declining, your creatinine is kind of inching up, and your total billy is 3.4 and your direct billy is 0.5. So what is the next best step in establishing your diagnosis of this issue?
Could be hemolysis, couldn't it? Or...
Perfect. Yeah, it is hemolysis. And so you have a patient who's had acute anemia that's primarily an indirect, and that's leading to pigment nephropathy and an increase in creatinine. And so the next best step is an LDH, and I would make sure that in your practice at your institution that you check an LDH at least daily on these patients, because sometimes we'll see a rise in LDH before we see active involvement within the urine. This is an actual patient pre and post hemolysis. But what I wanted to teach is anytime you use temporary mechanical circulatory support, look out for the complications because they're not infrequent. And if you identify them early enough, you can prevent very serious things from happening. So checking LDH daily. You can do a plasma-free hemoglobin. Unfortunately for us, it takes 4 days to get it back. You can check a UA for signs of hemolysis. And if any of these are inching up, you may want to adjust your Impella position, because sometimes it's sitting near the papillary, or maybe you can adjust your speed. You can decrease your RPMs a little bit. Always daily check arterial for arterial thromboses. You can do Dopplers and check the pulses. And the other thing, we had a patient that recently had an Impella after liver transplant. She had cardiac arrest and required an Impella. Unfortunately, she lost her pulses after the Impella was placed, and it wasn't occlusive. She was just small. And so one of the things you can do is you can ask your interventionalist to do a bypass, a pseudo bypass. So let's say you have the Impella in the right femoral artery. You can actually place a arterial line on the left femoral artery and Y connect it with the retrograde stick on the right femoral artery, the right SFA, and actually have flow come from the left femoral artery past the Impella distally. Does that make sense? So it would basically be a bypass to the foot that has the Impella. So if you have a small female, or you're worried about distal flow with the Impella, you can actually do a bypass, and that will actually protect the leg. And so we ended up doing it in that patient, and she, her pulses came back nicely.
Nice.
Check a hemoglobin intermittently, and then of course look for RV failure, because that can, as we mentioned earlier, that can happen immediately in the cath lab or later on. This is the leg. This is actually a patient that was transferred to us with an Impella in place. Looked very good, hemodynamically speaking, and we actually removed the Impella within a day of his transfer. And right when we removed the Impella, he complained of foot pain. Actually, interestingly enough, bilaterally. And he had clot extending his entire right iliac, profunda, and actually even on the left. So he had clot probably sitting in the aorta that showered both ways. And so we needed to take him to vascular immediately. It was lucky. So we have been, for Impellas that aren't placed with us, we have been actually explanting the Impellas in the cath lab, so that if something goes wrong, we can actually image the foot immediately. Or if there's a bleeding issue, we can actually use perclose or what have you. So that's another kind of best practices. So again, we're going to assess for potential temporary mechanical circulatory support related complications frequently. There we go. I'm going to skip this. This is just talking about correct positioning of the Impella. And I'm going to just review kind of the clinical pearls that we talked about and open it up to questions. But number one, we want to identify cardiogenic shock early before we move to cardiometabolic shock. You want to implement temporary mechanical circulatory support early prior to significantly escalating vasopressor or inotropic support. If you're on 2 drips, adding a 3rd or a 4th really is not going to help you at that point. You really need to start thinking about something stronger. I believe that invasive hemodynamics are essential in cardiogenic shock and temporary mechanical circulatory support management. Early on in cardiogenic shock, as we had mentioned earlier, you can get by with a poor man's swan to help you kind of manage. Cardiac power output can be influenced by LV function, temporary mechanical circulatory support adequacy, right to left filling, and remember, CPO can also be affected by vascular tone. Remember that a coding patient with temporary mechanical circulatory support is different than a patient without support devices. And then remember that if somebody has VT, you want to treat the VT, but you also want to identify the cause of the VT, okay? These are based on the prior talk, but remember, when do you wean the Impella? When do you take it off? You really want your hemodynamic parameters to be optimized, and you want your metabolic parameters to be near goal. So if your lactate was 10 and your lactate's 5, that's not the right time to pull the Impella unless you're having issues with it. And the reason why is you really want to get as much reserve possible before you remove the Impella, okay? Remember that management after the Impella is just as important as management as before. Consistently utilize your hemodynamics to decide, are there changes in the hemodynamics 1 hour, 6 hours later? Is the RV being supported, etc.? Look for those complications frequently, as we talked about. If you do have hemolysis or VT, as Taved recommended, do an echo, reduce your flow to reduce hemolysis for VT or adjust the Impella position. Again, identify the type of shock is important for patient management. And this one I didn't talk about this time, but last time, follow your labs and hemodynamics frequently. You cannot manage these people with daily labs and hemodynamics. And this is where we had to actually sit down and meet with our intensivists and kind of make sure that, because all of us are hardwired differently, but we wanted to kind of give our intensivists kind of an understanding as to why we follow labs frequently and manage these patients closely from a hemodynamic standpoint, because patients can change within hours and you want to be ahead of the game. And so we've had to give these same lectures I've given you, we've had to give to our intensivists to really try to make sure that all of us are working with the same background information and the same goals. And so with that, that's a lot of information. With that, I'd like to open up to questions. Thank you guys for your time. And I appreciate the opportunity to give you guys 2 lectures. I'm sure you're sick of me by now, but thanks so much for giving me the opportunity to speak with you guys.
That was
this was really great, Parag. Even as an EP, I learned from it a lot, and I think we all have to learn from this. And for those, just a reminder for the CME credit, look at the chat. There is the instructions about how to claim the CME. And again, if anybody has a question, please go ahead. But thank you very much again, Dr. Patel.
Thank you.
Parag, that was awesome. And yeah, I see the work, and I missed your first lecture, but I'm all into the data on the shock teams, and I've wanted us to form a shock team. And I think we don't do enough swans and right heart caths, and we need to be getting these numbers and meet again with you and go over some cases. That was really, really good. And please keep some cases and do it again with us in a couple of months. I learned a lot. Thank you.
Thank you. You know, it's really interesting when we, the reason why we developed our shock consortium here within our institution is about 2 years ago, we looked at our outcomes with Impella. And it was really interesting. The outcomes on our service, if you got an Impella on our service, we're talking about, and remember, we're separate from general cardiology. So if you got an Impella on our service, our outcomes were 42% mortality. If you got an Impella on the critical care service, it was around 78%. And so you got a very large difference, a stark difference in outcomes. And I think that the 3 big keys is early identification, appropriate patient selection, and appropriate management afterwards. And I think one of the things we realized is that that I think our critical care team was getting the Impella but flying blindly afterwards. And when there were complications that arise, there was one patient, for instance, who died of a retroperitoneal bleed after an Impella was placed. And like little things like having an invasive hemodynamic monitor may have allowed for them to troubleshoot a little bit faster. And so I am definitely happy. This is like a passion of mine. And I'm definitely happy to work with you guys in any way. And then also, if you guys have an interest, we do have a JACC Shock Consortium where we're trying to optimize cardiogenic shock within Jacksonville. And obviously with COVID, we haven't met. But prior to COVID, we were meeting almost quarterly and sharing cases. And it was really a learning, it was really a good opportunity for us to learn best practices from each other. And so if they're okay with it, I'll ask if you guys, if we can invite you guys, and if you guys want to join for that. It's a fun talk, especially, we used to do it in person, but we're probably going to move over to Zoom with everything going on. So.
That's great. And I already spoke to the intensivist here, Dr. Messina, maybe online. I'm not sure if he's on or not. He's also excited to be part of this new efforts, and hopefully it will be good for our patients and improve the survival and the care for everyone.
Hey, Parag, real quick. When I went to the last heart failure meeting, I went to a workshop on Impella, and they had software for your iPad. I'm not looking to cheat. But they had this incredible software where you put numbers in and it told you things to do. Is that something you advise?
Yeah, it's actually nice. So that's the Smart Assist, and it's funny you mention it because Mayo is like red tape world, and we've been wanting to get the Smart Assist started here forever, and we had to like throw in 20 applications to all these random people in Rochester, and finally got it approved and went live last week. And so you know, we were using the Smart Assist technology beforehand, but now we have the ability to look at it at home. But in terms of Smart Assist technology, the nice thing about it is if you have a Swan in place with the Impella, what you're going to be able to do is separate output based on the Impella as well as the native output of the left ventricle. And so the nice thing is you're going to be able to, over time, like if somebody's in shock, you'll see the Impella is doing a majority of the work, and the left ventricle natively is not doing much. And then over time, you're going to see as you improve the heart that the LV kind of catches up to the Impella, and that gives you an idea as to the right time to wean down the Impella. And the other nice thing with the parameters that they give you is they actually give you cardiac power output on the actual monitor with the new Smart Assist device. And so I think it is worth you guys getting it. It's only a quick software change on your consoles, and you should be able to utilize it. And so it's very useful. But again, you're going to need a Swan to utilize that. So just keep that in mind.
Thank you.
And the last thing I'll say is if there are ever questions, you have a patient in the ICU and things aren't making sense, call me. I'd be happy to help out. It just takes, I'll be honest, it takes about 3-4 of these patients to kind of make it automatic in your head. But it starts making sense as you just keep on utilizing the CPO, the POPI, and everything else. It starts making sense over time. So
that was great. Thank you very much, and thanks to all for being part of this, and looking forward to next month's one. Thanks again.
Thanks again. Take care, guys.
Thank you.
Thank you.